Assalamualaikum, Dr. Munira. So for the second round of proposal, after the feedback to narrow down to more specific scopes, the title of the proposed study has slightly changed to Understanding Community Resilience in Klang Valley Throughout COVID-19 Crisis. So this is more specific in terms of the location as well as the components of that will be studied regarding community resilience. As of January 2020, the COVID-19 pandemic has already reached up to 100 million cases, claiming the lives of approximately 2.15 million people already. So this actually indicates a very serious health crisis with the increasing cases, increasing deaths, and also it indicates social, economic, and geopolitical crisis as well. So according to a report on the assessment of Malaysia's health security released by WHO in November 2020, Malaysian government requested for a voluntary Joint External Evaluation (JEE) of international health regulation core capacities, which was conducted with WHO itself in the late 2019. And because it is conducted in the late 2019, which is almost at the same time as the pandemic outbreak, this actually contributed to the resilient public health system in Malaysia, which coincidentally established a stable foundation for the outbreak response to the ongoing COVID-19 pandemic in this country. So in addition to the resilient public health system, Malaysia also went through a Structured Movement Control Order (MCO) during its first round in 2020, followed by Conditional Movement Control Order (CMCO) and then Recovery Movement Control Order (RMCO). So these two factors, which are the resilient public health system as well as the control orders, are seen to have contributed to Malaysia's effort in keeping a considerably lower amount of pandemic cases as well as deaths. However, with the control orders, whether it's MCO, CMCO, or RMCO, this situation actually demonstrates a globally unprecedented state of vulnerability, or now commonly known as the new normal, whereby we observe social adjustments that involves a series of changes to accommodate basic community or society functions that are resuming. Therefore, due to various adjustments defined as livelihood interruption, there are actually several concerning social and economic drawbacks such as job loss, socio-economic discrimination, lack of access to basic healthcare, loss of livelihood quality, and work-life conflicts, which are actually the impacts that were experienced by Malaysians during the first round of MCO, CMCO, and RMCO. Starting October 2020, Malaysia entered its third pandemic wave after watching a sharp increase in the number of infected cases and deaths, which triggered the Malaysian government in January 2021 to once again implement the second round of MCO and CMCO. This time, the response of public is very different compared to the first round of MCO and CMCO. They are divided between health and economy as priorities that should be focused during the mitigation of the pandemic at this current situation. Both health and economy are factors which directly affect the livelihood of society of different levels across B40 all the way to T20 categories. The response is such because of how the public experienced the drawbacks during the first MCO. And the response by the public indicates a mutual concern, which is the resilience during the pandemic. If prolonged with no viable solutions such as a national roadmap for recovery, the socially and economically vulnerable groups will be unable to sustain themselves. As of now, there is a lack of robust community resilience framework in Malaysia, whether in response to disasters or pandemics. Therefore, this study proposes to identify and analyze the socio-economic indicators of community resilience during COVID-19. And once these indicators are identified, they will be used to study and compare the resilience in two types of communities in Klang Valley, which are the B40 and the M40 communities. For the first part of literature review, it focuses on the definitions of community resilience. According to a very extensive study done by Patel in 2017, there is actually no rich consensus on the definition of community resilience and its core characteristics, with mixed definition appearing in scientific literature, policies, and practices. Bonanno in 2015 defines community resilience as the interaction between individuals and their community and refers to the success of the community in providing for the needs of its members and the extent to which individuals feel supported by their community. According to Communities Advancing Resilience Toolkit, CART, a resilient community is described as one that has the ability to transform the environment through deliberate, collective action and requires that the community as a whole must cope effectively with and learn from adversity. Conjoined Community Resiliency Assessment Measures, CCRAM, define community resilience as the community's ability to withstand crisis or disruptions. According to Muhammad in 2019, resilience is a term emerging from ecology to reflect the system's capacity in maintaining and restoring functions in the event of disruption. From a medical point of view, community resilience resources for both professionals and whole organizations may involve deliberate efforts to maintain connections via communication of COVID-19 policies and their implications. Patel's study in 2017 identified three general types of definition, which are process, absence of adverse effects, and range of attributes. Therefore, from here we can see that there are very different definitions of community resilience, and it depends on the studies, the communities, as well as the situations. However, we can also see some overlapping characteristics of the definitions themselves. The second literature review focuses on the elements of community resilience. According to Patel in 2019, the study has identified 9 main elements with their respective sub-elements from their extensive literature reading in their study. The 9 elements are local knowledge, community network and relationships, communication, health, governance, leadership, resources, economic investment, preparedness, and lastly, mental outlook. The third part of literature review focuses on community resilience indicators. So in the study conducted by Muhammad in 2019 on the resilience of urban community in Putrajaya, the localized indicators are explained through several sub-themes, which are economic capital, social capital, and environmental capital. The indicators can be seen in the next slide, where they are categorized specifically under each capital or sub-themes. A survey done by Kim Hee in 2020 refers to the Community Resilience Scale by CCRAM 10, in which 5 issues are used as indicators, which are social trust, social support, leadership, emergency preparedness, and attachment to place. A study done by Lau in 2020 regarding the resilience of Hong Kong people in the pandemic have been identified through 3 key lessons, which are also used as indicators, which are establish personal vigilance, mental health crises, and social and community support. There are 2 problem statements that are identified in this proposed study. The first one is, since there is little research on community resilience during a pandemic being done in Malaysia, if we don't identify the indicators of community resilience in such situation, it can actually be quite challenging for us to sustain the community as well as to help this community to recover from the pandemic. Therefore, addressing this problem will be able to help us by providing additional indicators to add on to a fundamental, hopefully a robust, community resilience framework for pandemic. The second problem statement is, As the pandemic forces Malaysians into a situation whereby they are divided between prioritizing health or economy during the mitigation measures, having a fundamental understanding about community resilience through the citizens will be able to assist Malaysia as a nation to find the balance between health and economy throughout the pandemic mitigation. Therefore, the research question is, what are the key indicators to measure and compare community resilience across different communities during COVID-19? These are the proposed research objectives to identify the key indicators of community resilience in response to COVID-19, to analyze and study the key indicators of community resilience in response to COVID-19, and finally to study and compare community resilience between B40 and M40 communities in response to COVID-19 using the key indicators identified. In general, the methodology involves 3 steps. The first step is conducting a systematic literature review of definitions of community resilience related to pandemic or of similar situation and its key indicators. So this involves identifying elements of the community resilience, doing publication screening, as well as referring to Community Resilience Index and also Malaysia's community resilience during the 2002 to 2004 SARS outbreak. The second step is to conduct an online survey using stratified random sampling, where there will be a 1-month survey conducted in Klang Valley targeting 200 individuals aged between 20 to 40 years old. These individuals are divided into strata according to B40 and M40 classification. Last but not least, there will be a statistical analysis of the data collected from the online survey using SPSS. There are 3 limitations worth mentioning for this proposed study. The first one is there can be limited publications and studies done on community resilience in COVID-19, especially in regards to Malaysia. Therefore, it is recommended to conduct literature review on general community resilience in Malaysia, community resilience towards disasters or similar pandemics such as the first SARS outbreak in Malaysia, and then community resilience towards COVID-19 in any countries. Second limitation, there are various definitions of community resilience. Hence, it is recommended to relate the definition that suits Malaysia and its current pandemic situation. Lastly, in regards to sampling method, overlapping can be an issue if there are subjects that fall into multiple subgroups. So the results can be a misrepresentation or inaccurate reflection of the population. Hence, it is recommended to strictly follow the primarily determined B40 and M40 categories.